It was dubbed Strang Cancer Prevention Institute, past, present, future, a gathering at the posh New York Athletic Club on Central Park South. The host, Dr. Michael P. Osborne, president of Strang Cancer Prevention Institute, now celebrating its 80th anniversary as the first institution for the early detection of cancer.
Well, good evening and welcome everybody. Thank you for coming out, and thankfully it's a very beautiful evening in New York, so very happy you're here. I'm Dr. Michael Osborne, I'm president of Strang, and we're really today just marking a few things. What I'm going to mention is Strang itself. We're now 80th year now. Technically speaking, it was opened by Eleanor Roosevelt in 1933 with the founder of the institution, Dr. Elise Strang L'Esperance. Many of you have heard this before, so just don't pay any attention. But it's a very interesting circumstance of Strang's founding. Dr. Elise Strang L'Esperance was one of the first women graduates in medicine in New York. This would be in the 1930s. Well, I would say in the 20s, actually, 1920s. And she went into pathology and was the first trainee from the Cornell pathology department, first woman trainee they ever had. Again, this would have been in the 30s, early 30s. She had noted the work of another member of the faculty of Cornell Medical, who was really in the wrong department. She was in the pathology department. This individual was in the anatomy department, and she was very interested in his work. She was very motivated. Her mother had died of cervical cancer. The work that she observed was being done by Dr. George Papanicolaou. There wasn't an attending gynecologist at Memorial Hospital or the New York Hospital who believed a word of what he was saying. The outrageous claim that he could tell who was going to get cervical cancer. And she had a rich uncle. Those are the vital ingredients. The rich uncle was actually the New York Senator Chauncey Depew, and he was a very rich uncle. I believe he was one of the barons of the New York Central Railroad, amongst other things. So with his money and her motivation and her belief in Dr. Papanicolaou, she took the work downtown. And the development of the Pap test was really conducted downtown New York, not at Cornell, who now have Papanicolaou's bust in the main hallway. Yeah, that's the guy they didn't believe. And we're very proud to have been a part of it, and Dr. Elise Strang L'Esperance won the first Lasker Prize for the introduction of the Pap test, and the number of lives saved worldwide are in the millions from that test alone. So it was really a home run on the first thing out of the gate there, so it was really quite amazing. We've done a lot of work in other areas. We were one of the first institutions to recognize that you could detect polyps in the colon, and that they led to cancer, and if you had them removed early on by getting a checkup, you wouldn't get colon cancer. Now we progress to the days of colonoscopy, and everybody over 50 here should be having one, and if all is well, every 10 years. If you have a polyp, that's fortunate it's been found, and then you're on a bit of a more frequent schedule. We've done work with lung cancer and a variety of different cancers. Our vision now, and the institution's morphed through several forms, which include downtown, which include Memorial Sloan Kettering, include independently as the largest screening center in New York through the 60s and 70s on 34th Street, to an affiliation with Cornell, and now is very independent, but is working with any hospital that wants to hear more about cancer screening and prevention. And that's one of our main missions now, is cancer screening and prevention. So if you're interested, and you're over 40, you should go to strang.org, and you will find under screening and prevention everything you need to know about if you're at risk, or if you're not at risk, and what you should be doing and when you should be doing it. And for the major cancers, such as breast, cervical cancer, colon cancer, lung cancer, and prostate cancer, you will find a lot of information on the frequently asked questions that patients would ask about what these procedures involved. Because although the American Cancer Society sort of preach screening is actually apple pie and people are stunned when they get cancer when they're being screened, they don't think that should happen. Screening doesn't really prevent things happening except with colonoscopy. You'll find all that information there, and it's quite a resource. So we are very interested in bringing this information to get the maximum impact to primary care physicians, and we're working with the Mount Sinai Health System with a very large department of primary care, looking at ways to enhance primary care physicians' compliance with all these cancer screening guidelines and possibilities for prevention. And beyond that, we'd like to see the program, the Strang program, taken to other major healthcare systems in the United States. Mount Sinai is at least one of the largest in the northeastern United States, but we'd like to see it go beyond that. So that's what our sort of more immediate future is. So on the back of your program, you will see the names of all the people who have helped us, and I won't go through them all. They know who they are, and they know we're very appreciative of them putting this together. I will pick out first our sponsor for this evening, who's helped us a great deal. That's Doug Anderson and Diego Pellicer. Is Doug there? Doug is he's at the back by the bar, appropriately positioned, and he's just joined our board of trustees as well. Of course, I want to thank Merle very much for putting together. Merle Barish is on our board. She's secretary of the board. She's very good at events, and she's pulled all this together from scratch. I said I couldn't do much to help other than provide information and maybe some names of people who are on my secret list, who may know who they are. Somebody laughed rather loud then. Now you're not on the secret list anymore. So, we're very appreciative of Merle. I'm going to ask Merle to come on up and talk a little bit about one of the focuses of this evening. Beyond Strang's general interest in screening and prevention, she's going to introduce why we're interested in this particular arena. So, come on up, Merle.
Good evening. For many years, I have given back to Strang, as Strang has given so much to me. Tonight, I'm proud to celebrate Strang's accomplishments and to be a part of assuring its place in American history by continuing to carry out its mission to save lives. Early detection through research to prevent and promote cure would have resulted in my dearest friend, Diane Zola, being here tonight, but sadly she lost her battle with ovarian cancer. Diane was a genuinely beautiful person, inside and out, a loving friend, a sister, a wife, a loving mother to Dan and Brian here tonight, a wonderful mother-in-law, and she loved her role as grandmother. She will always reside in the hearts of those who love her. In her honor, we have created the Diane Zola Ovarian Cancer Research Fund. With this fund, we will contribute to creative collaborations for cutting-edge research so that everyone's Diane can live their life to the fullest. Thank you.
Thank you, Merle. And I was privileged to know Diane as well personally, and she's not only everything you said, she was also a trained nurse. So that was a wonderful experience meeting her. So ovarian cancer has been an enormous black hole for which there's been no real good chance for early detection or prevention. We all know, it wasn't on the list of 5 that I gave you of the major adult cancers that are prevalent in the United States and cause a great deal of morbidity and mortality in the population. So the focus is on ovarian cancer, and there's no one better to tell us a bit about what's going on and some of the exciting developments than Dr. John Koulos here. John I've known since we were back in Sloan Kettering in the 80s, early 80s. He's had a stellar career both at Sloan and at Columbia and a whole group of other places I can't remember right now. And been very fortunate to work with him for the last few years. Everyone in my sphere of practice, which has been breast cancer, and that is a link to ovarian cancer often enough, John's taken care of superbly. And they tell me, and I knew already, he's a tremendously good gynecological cancer surgeon. So John, please come up and just tell us what prospects are there for us to detect ovarian cancer.
I would like to thank Dr. Osborne and the Strang Institute for the privilege of speaking with you tonight. I'm going to speak about a novel method in the detection of cancer using pap smears, the pap test. We know that cervical cancer has been the leading cause of cancer-related death among women in the 20th century. However, with routine screening with pap smears and now with the human papillomavirus screening test, the incidence and mortality from cervical cancer in the U.S. has fallen dramatically. And in fact, since the introduction of the pap smear, there's been a 75% reduction in the incidence and mortality in screened populations. And as you know, when Dr. Osborne mentioned George Papanicolaou, his seminal work in the diagnosis was the diagnosis of uterine cancer by vaginal smear. It was published in 1943. And Dr. Papanicolaou suggested that endocervical sampling could in theory detect not only cervical cancers, but other female reproductive tract cancers, including endometrial. Endometrial and ovarian cancers are now the most common gynecologic malignancies in the U.S. There's 15,000 ovarian cancer deaths annually and 8,000 endometrial cancer deaths annually. But in contrast to cervical cancer, there's really a lack of an effective screening option. So there's a great interest to establish new approaches in the diagnosis of ovarian and endometrial cancer. For screening of gynecologic malignancies, for endometrial cancer, the focus has been on transvaginal sonography, ultrasound, to measure endometrial thickness that would raise a suspicion of an underlying malignancy. For ovarian cancers, the options have included transvaginal sonography, ultrasound, and the serum cancer antigen, the CA-125 blood test. But outside of the patients who have hereditary cancer syndromes, the breast ovarian cancer syndromes, the patients with BRCA-positive gene mutations or Lynch syndrome, most of the guidelines, including the U.S. Preventive Services Task Force, have recommended against routine screening for endometrial and ovarian cancer because of the lack of sensitivity and failure to demonstrate any survival benefit. However, there's 3 or 4 major recent studies and ongoing studies for ovarian cancer screening. One study by the prostate, lung, colorectal, and ovarian cancer screening trial looks at ultrasound and CA-125 levels. The problem with this is there's a high serious complication rate in women that are undergoing surgery for false positive findings. The University of Kentucky is performing annual ultrasounds, but it's not a randomized controlled trial. There's a Japanese cohort study that's looking at ultrasound and CA-125. And their findings have led to a detection of ovarian cancer at an earlier stage. However, the mortality rates have not yet been reported from this study. And probably the largest trial to date is the UK collaborative trial in ovarian cancer screening, which is a randomized controlled trial. And they're performing on their patients annual screening using either transvaginal sonography or CA-125 is interpreted by what's called a risk of ovarian cancer algorithm, with using transvaginal sonography as a second-line test or a multimodal screening. They're demonstrating some superior sensitivity for the detection of ovarian and fallopian tube cancers, but the mortality data is still yet to be reported, and that'll be in 2015. It's interesting as an aside that our understanding of ovarian cancer has taken a little bit of a shift over the last 1 or 2 years, with an understanding that perhaps more likely ovarian cancer is actually originating from the fallopian tube as an early precancer of the fallopian tube and later implanting on the ovary. And this is actually going to impact some of our approaches to patients that are BRCA positive when we recommend prophylactic removal of the tubes and ovaries. We may be actually doing a 2-stage procedure, removing fallopian tubes at a younger age and thereby allowing hormonal preservation for preserving the ovaries and removing ovaries at a later time. So again, the pap smear in turn was introduced in the 1950s, as I mentioned, and there's 2 methods available for pap smear screening. One is a conventional method by just scraping cells off the cervix and the endocervix and putting them on a glass slide read by a cytopathologist. However, in the mid-90s, with the introduction of liquid-based cytology, it presented the option to perform DNA analysis on the human papillomavirus. So this has led to a greater information and detection of earlier types of cervical lesions. However, the pap smear, the conventional pap smear, has limited utility in diagnosing endometrial or ovarian cancer. With conventional cytology, it's possible to pick up maybe 30 to 40% of early endometrial cancers. However, in ovarian cancer, conventional cytology or pap smears only yields maybe upwards to a 15% sensitivity. But however, with the liquid-based preparations now, using polymerase chain reaction, PCR, we can detect in cervical lesions high-risk HPV subtypes. And this has been a breakthrough in cervical cancer and cervical pre-screening for precancers of the cervix. So there's a group at Hopkins led by Kindy, also in collaboration with one of my colleagues at Sloan Kettering and also the Cancer Institute in Sao Paulo, Brazil, that have tested DNA, have used DNA to assess gene abnormalities in endometrial and ovarian cancers. We recognize that all human cancers result from mutations in a limited set of genes, and then even a more limited set of pathways through which these genes act. So Kindy and his group analyzed particular regions of 12 specific genes, and they detected 12 genes in gene mutations in 9 different gynecologic cancers, mainly endometrial and ovarian subtypes. So they developed what is called a PAP gene, and that's a compilation of a panel of 12 genes that represent the most common mutations in endometrial and ovarian cancers. And they put this together, and the PAP gene was used, can be tested on pap smear samples from patients with known endometrial. So they initially did PAP gene testing on a group of patients with known endometrial and ovarian cancers. And they could identify mutations with rates as low as 0.1% mutant copies. Of the patients without cancer, there were no mutations detected using the PAP gene. They tested 46 patients who had endometrial and ovarian cancer. Now, is it a good screening test? So one strength of the PAP gene is that obtaining cervical cytology is very well established, it's routine, and it's very well tolerated by patients. In the 46 patients they tested, they demonstrated a strong sensitivity for the endometrial cancers. All 24 of the endometrial cancers tested positive by the PAP gene. But unfortunately for ovarian cancer, the sensitivity is much less. Only about 41% of those patients tested positive on the PAP gene test. And this could be a reflection of ovarian cancer biology. One of the limitations is that in this particular initial study with that is that the specimens from the women with ovarian cancer were in an advanced stage. But perhaps improvements can be made on obtaining the specimen. Perhaps collection methods such as using a small cannula introduced into the uterine cavity could theoretically allow a more enriched sample of cells coming from the fallopian tube and the ovary. So, in summary, screening should be a relatively inexpensive test. Evaluation of HPV DNA in cervical cytology is already part of our routine pap smear specimen and testing because HPV increases the test sensitivity. The DNA purification component for the PAP gene test is similar to that for HPV analysis, so this component is also feasible for use in patients. The preparation of the DNA with the amplification and sequencing of the gene, of the PAP gene, can be performed at a cost that should be comparable to that of routine HPV testing in the US today. So this actually lays the foundation for a new generation of screening tests. Thank you very much.
Thank you, John. Well, you put it very succinctly. I learned a few things myself there. It does show there is some light at the end of the tunnel. As we say, that might be light at the end of the tunnel, or it might be a train approaching, but we'll go with the real light at the end of the tunnel. So the mere fact that even though it was half, or just under half of the ovarian cancers were detected by the PAP gene test, is encouraging in 100% of the endometrial cancers, which up to this point there is no screening test that's been proven to be of any value. Now, these have got a long way to go to prove early detection, and the end result has to be a reduction in the death rate of that cancer. So this is a very, very long way to go. But we're very excited about it. We're also doubly excited because of our involvement in the bringing the PAP test to clinical use and now finding it's got another use again. So I find that very fascinating and interesting. So thank you, John, for giving us some idea of what might be down the road for us. And the last part is an area that we at Strang have been researching for years. When we were up at Cornell, we've done a lot of research in this arena, amongst other things, but is, I think, an area of great interest to the general public, and that is the role of nutrients, botanicals, in health in general, but in cancer prevention specifically. And our group, of whom several are here tonight, have published extensively in the cancer literature and cancer meetings on various nutrients that have very powerful effects and have tremendous promise for prevention. So I'm going to ask George Wong to come up and join me. George and I also go back to Sloan Kettering. Come on, George. In the 1980s, he worked with me on my research as a statistician. George, I will say, comes from Hong Kong. He's got two halves to his brain. He's got the western half, where he has a PhD in statistics from Harvard. And he has the eastern half, where he has mastered the 5,000 years science or evidence and, how can we best phrase it, the knowledge that's been acquired in Chinese medicine. And he's trying to combine our Western scientific approach to 5,000 years of Chinese medicine, and I think some remarkable results are occurring. So George, please tell us what you've been doing and what you are doing and what you're going to be doing.
Thank you. As Michael said, I am a statistician by training, but I'm actually an herbalist by tradition. And I have been involved with the healing art Chinese medicine since 19 1982. And my interest is not in the botanical extracts, mostly in unprocessed raw herbs. I'm comfortable with herbs for women's health issues. And over the years, I've come across a number of herbs that are effective for the management of symptoms of hormonal imbalance and benign breast problems. And the question is, can such herb be useful for breast cancer prevention? And in 1995, I was able to convince Dr. Michael Osborne to start a herbal medicine program. Remind you, that was 1995. It was very advanced in thinking. And Michael, to my surprise, approved the idea. So we actually had the first program in herbal medicine in Strang. And the idea is to offer nutritional and herbal educational consultation for health enhancement purposes, not something for treatment. Now, most subjects enrolled in, I call it HMP, herbal medicine program, are women at risk for breast cancer. They are either in treatment or recover from breast cancer treatment. When Strang closed in 2008, we have over, I would say, 1,000 women in the herbal medicine program, and for secondary prevention of breast cancer. And here's my observations. For those who have enrolled in the program, I observed that the level of estradiol E2 is consistently lower than those who do not take herbs. In fact, I think in 2007 or 8, there was a presentation in San Antonio Breast Cancer Symposium that they studied many kinds of herbs and supplements. They found out that those who take herbs and supplements or phytoestrogens, they usually have lower E2, and this is an observation. So therefore, and also I observed that there are less number of breast cancer related events when they are on the HMP, the herbal medicine program. Also, quality life is usually better. Now, the median follow-up of my program at Strang was about 5 years, so it's not long enough to say that to say how effective it is in prevention. But I think there was about 20 to 30 relapses over this from 1995 to 2008. So that's pretty good results. I think about 5% relapse rate. Now, it's important to have basic science is needed to elucidate some mechanism of action. And in 2005, we're lucky to get close to $1 million from a patient family foundation to start the basic science research. And so I put together a research team consisting of Dr. Diane, who's in the audience here, and Dr. Leon Bello, who's sitting there too, and also Dr. Selkovic and myself. And we use this cell culture model, MCF7 cell culture model, to investigate herbs that are useful in my herbal medicine program to see what they are useful prevention of estrogen receptor positive breast cancer. And we have identified, I would say, about 13 different herbs of a nutritional nature that to me holds good promise for long-term prevention. And our team have made 5 presentations at San Antonio Breast Cancer Symposium over these years, and published 4, neither is 4 or 5, I forgot, about 4 to 5 peer-reviewed files. So peer-reviewed papers on some of those herbs. Now the herbs are anti-estrogen in two important ways. The first one is that it favors the metabolism of E2 in favor of a good metabolite 2-OHE1 and then rather than the promotive 16-alpha OHE1. And second one is actually it's very interesting. Only herb I think herb can do it is to detox or to convert the 16-alpha OHE1 into E3, which is not promotive. So that's I think one of the few ways you can detox the 16-alpha. Now, of course, it's important to establish human relevance through pilot prevention trials using validated biomarkers of risk. Now, the purpose of a pilot study are two. One is to assess the safety profile of the botanical. Second is to estimate an effective dose range or dose schedule for full-scale prevention trial in the future. Now, Michael and I are interested in pursuing the first pilot trials of Goji Berry, which is one of the botanical that I published, show that it's pretty useful in prevention of breast cancer, ER-positive breast cancer. And Goji Berry is a very popular nutritional substance you can buy in most stores. They're slightly greasy, but so don't overeat it. So so hopefully tonight we can maybe get some idea where we can get some money to do the prevention trial. So thank you.
Just to follow up on a couple of things, when I came to Sloan Kettering in 1980 and was invited to join the staff there, I was academic, I was interested in research and had done a lot in the UK. And I spoke to the chairman of surgery who recruited me about opportunities to do research at Sloan Kettering. Well, suffice it to say that there was a kind of scenario where the scientists didn't really talk to the doctors too well. I hope that's changed in more recent years. So I said, I don't think I can stay on here because I don't think there's much I can do. And he said, well, there's one other possibility. There's a group at Rockefeller University who are interested in breast cancer. And I will say on the side, Rockefeller University is even more notorious for not talking to doctors than the Sloan Kettering Institute. But I followed up and I found Dr. Fishman, who was fairly well disposed to me as he'd done his postgraduate studies at Oxford University. And we thought we could do something, and he immediately introduced me to Leon Bradlow, who was very wonderful to me. They said, here's a closet at the end of the corridor, it's a storage room, that used to be a lab. So on a weekend I cleared the whole thing out, cleaned it up, and I got myself a nice little lab at Rockefeller University next to Leon. And he trained me, and we did work a lot on a variety of things, and one of the most interesting things was this estrogen metabolism that George is talking about. And it's wonderful to see you here, Leon, because you're probably the main reason I stayed in the United States. Prestige of Sloan Kettering, of course, was a big pull. The research part was very important to me, and we did a lot of work. And so what George is alluding to is, which Leon Bradlow named, is the good estrogen and the bad estrogen. So everybody produces estrogen. Women produce estrogen, which is broken down, and it's broken down into a good one mostly, but into a bad form in a much smaller percent. But it's a percent that we found was increased in women who had breast cancer. And that particular bad hormone that's the 16-alpha hydroxyestrone he was talking about, has some unique properties that we believe, still do, no one else does of course, that it might be an initiator promoter of breast cancer. The only thing I really contributed to that study with Dr. Teelang there was we were able to show that a woman's breast tissue who had had breast cancer produced 500 times more of this hormone than the breast tissue of a woman who hadn't had breast cancer. To this day, it's still not, I would say, widely accepted. Yet, to this day, there is no real other player in the breast cancer research area on the one thing we know, which is hormones, estrogens, are related to breast cancer. We know that women, if they have their ovaries out before the age of 35, never get breast cancer. So the possibility of an approach using botanicals to alter these hormonal distributions, get the bad estrogens out, and promote getting the good ones in, is very exciting. The Goji Berry is the latest one, but George is very modest. We studied indole carbonyl from cruciferous vegetables. It certainly looked very interesting. Mushrooms. What else? Netten?
We looked at soy isoflavones.
Isoflavones.
Green tea polyphenols.
Which?
Green tea polyphenols.
Green tea. Yeah.
Some little bit works like curcumin, the yellow turmeric.
Turmeric. That great stuff in curry. Turmeric. Yeah. Sorry, I'm doing the English pronunciation. We call it turmeric, don't we? Has it got another name?
It's also known as curcumin.
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 Curcumin. Right. Okay.
Turmeric is the source where the curcumin is found.
Now, it is a matter of great interest to the American public because the American public spend more on these kinds of areas of treatment, non-traditional medical, than they do on medical. Across the country today, it's billions more spent by the public on also a lot of things that are completely useless. I mean, completely useless, and the word still hasn't got out on how completely useless many of those things that are being bought over the counter in the pharmacies and the nutritional stores are. So anyway, I want to thank you, George, for that, and I hope we can continue that work in a population of women who are at very high risk for cancer because of their family histories and other factors. So that's all we really have to say. We went a little bit longer than we should. It's very my fault. So thank you for coming. Thank you for listening. If you want to ask Dr. Wong or Dr. Koulos or myself anything, please feel free. We'll be hanging around for a while yet. Oh yes, thank you. Yes, and in the meantime, get your credit cards out because over there is some fantastic stuff for women mostly, which is at knockdown prices. Forget Century 21. This is top-notch designers at a fraction of the price. And those guys here, if you want some brownie points, you better head over to that table. So thank you all for coming, and please stay around and talk to us if you have any questions. Thank you very much.
Strang Cancer Prevention Institute, dedicated to research to prevent cancer and promote cure through early detection.